We look forward to working with you in 2019-20.
Good afternoon, everyone, and welcome to the WCMICS Annual Forum, a year in review. I'm Michael Barton, Quality and Performance Manager at WCMICS, and I'll be your host. Just some brief housekeeping. So toilets are on this level, just out to your left out of that door. And in the unlikely event of an evacuation, we'll just follow the directions from the area wardens. So with that out of the way, I'd like to welcome WCMICS Chair and CEO of Melbourne Health, Professor Christine Kilpatrick, and our Director, Jeff Szer.
Thank you very much, Michael. And as you heard, Chris Kilpatrick's my name, and I'm delighted to be here today, particularly in the role of the Chair of WCMICS during the past year. So again, can I also welcome you here to WCMICS Annual Forum for 2018-19. And as we meet here in this magnificent building, I acknowledge the traditional owners of the land on which we meet and which this VCCC building is built, and pay my respects to their elders past and present. Tonight's forum is an opportunity to hear about some of the great work WCMICS has led and undertaken over the past 12 months as a result of the work of a wide range of dedicated individuals and organisations, from the Department of Health and Human Services through to our partner health services, consumers and statewide integrated cancer service colleagues. Through ongoing collaboration, networking and an innovative grants program, WCMICS continues to assist partner health services implement cancer care quality improvements and improve the outcome of our patients with cancer and the lives of their families. Tonight, we will see the launch of the pancreatic patient videos, which have evolved from the rollout of the National Optimal Care Pathways. We will be taken on a metro regional patient journey through Rhonda's story. We will hear about creating a personalised survivorship care plan. We will learn about the Prehabilitation Program for patients with prostate cancer. We will also hear about some initiatives in the nutrition space, and finally, work related to pregnancy and cancer. So there's a lot of ground that we will cover tonight. So tonight is a wonderful opportunity to stop, to reflect on the work WCMICS has undertaken over the past year and has been involved in, and the potential for building on this work over the next year in 2019-20. So thank you for taking the time to be with us tonight, and I'll now hand over to WCMICS Clinical Director, Jeff Szer, for some further words, and then we will hear from our guest speakers. So again, welcome and thank you for being here.
Thank you, Chris. It's been fabulous having Chris as the chair of our governance committee for the last 18 months. I don't think she could pronounce WCMICS when we first asked her to join us, but she's very much over everything that we do now, and is actually assisting us greatly in keeping our bits and pieces all aligned and running smoothly. So thank you, Chris, and it's been fabulous. Many of you know I've been at this for a decade or more, I think, by now, and I'm pretty much aware of how complex what we're trying to do has been, and very grateful that we're able to get together from time to time and share some of the great work that you all do. So before I hand over to the first speaker, I'd like to thank everybody. I think that's my role, is to thank everybody. That's mainly what I do in our work, including the directorate team, led by Kath Quaid, who nobody in the room shouldn't know. And we have a long association. In fact, I initially was on her interview panel when she came to Melbourne to function as a nurse unit manager in our department. So it's been a long and interesting ride, Kath. Fabulous. So please don't hesitate to ask any of the directorate people any questions about what's going on, what we're doing, what we plan to do and what we're required to do. A lot of the team are here today and have helped put all this together. So there's also, you've picked up your little pieces of paper. Our annual report is available on the website, and if you're clever with QR codes, there's one on one of those bits of paper that will take you straight to it, but you can easily link to it from the WCMICS homepage. I'd particularly like to thank the Governance Committee that Chris chairs for steering us correctly and making sure that the dollars that we're entrusted with are spent wisely and that the output that we achieve is what we intend to. Our Clinical Management Advisory Committee that's composed of a number of very engaged individuals who are helping to steer the scientific and other direction of our work, and all of the engaged clinicians of all disciplines for what they do for us and with us. Everything we're doing is integral to our aim of improving patient care throughout our service and its various partners. And I'd also like to thank the consumers. I've met at least one here today, but there are more, for the important work that they do and the increasing work that they will do on our committees, and we hope to bolster the numbers of those in our various pieces of work as we move forward. We haven't been ignoring you, we've just been getting our feet wet for the first decade or so of the Integrated Cancer Service workflow. So I hope many of you are able to stay until the end and have a chat and glass of wine. I don't know what we've got to do. No wine, not allowed to do that. Once we finish, I apologise for having to run out. I'm having a clinical trial audit happening at the moment, so I've got to go away and be yelled at for an indeterminate amount of time, but I will come back. So thank you, and I'd like to, I think I'm handing back to Michael to introduce the first formal speaker, so have a great afternoon. Thank you.
Thanks, Jeff and Christine. So we'll move on to our first project presentation of the evening. So Chris Caudle and Trish Calder are the joint project managers for the Metropolitan Regional Collaboration between WCMICS and the Loddon Mallee Integrated Cancer Service. And they're going to present a piece that has come out of that collaborative work, which is called Rhonda's Story. So please join me in welcoming Chris and Trish.
Just do this.
No, that's not.
And
That's it.
yeah.
Well, I'm delighted to be able to tell you a little bit about the Metropolitan Regional Engagement Project, which Michael has just mentioned. This was a project, a collaborative project initiated by WCMICS in collaboration with the Loddon Mallee Integrated Cancer Service a little over a year ago. And the aim of the project was to explore issues and gaps related to the transfer of patients between regional and metropolitan areas for cancer treatment. So it was initially a one-year project, and it's been extended now for another year. So we're just going to elaborate on a couple of dimensions of that.
So in the first year, it's mainly been an engagement project. So we've spoken to lots of key stakeholders in the metro and regional area, and we've come out with two main themes, and that's around transition and communication. We've done a lot of products for this first year, but tonight we're just going to focus on the three main products. So when we were speaking to the metro clinicians, they kept on saying, we waste all this time trying to link people back to services closer to home. And we said, well, what about just having a directory which got our map? You click on, say you want to get someone back to Swan Hill that needs to be linked to a palliative care. You click onto Swan Hill, you scroll down to palliative care. It has the referrals, the contact details there. And they said, that'd be great. So we put that on our website. So it's the one in the middle down the bottom. So that's on the LMICS website. And the other one we're focusing on tonight is the Navigator, which Chris wanted to talk to.
So the first one was looking at patients coming out of the metropolitan area back to Loddon Mallee, but then we're also aware of the needs of patients with cancer coming from Loddon Mallee down to the metropolitan area. And so we just wanted to create a one-stop shop for these patients to make it easy to find their way when coming down to Melbourne. So we came up with the idea of maybe a hierarchy of needs down one side of the matrix. You know, where do I park? Where do I stay? Where do I get groceries? If I need a support worker or a translator, how do I find that? And across the top of this interactive PDF are the metropolitan hospitals. So what we've done is to pull all those websites which exist into one-stop shop. So if you wanted to find, say, a pastoral care worker at the Alfred Hospital or the St Vincent's Hospital, you just click on that spot, comes up, the phone numbers are there and can find it be found very easily. And so we've been working with a lot of volunteers in the regions, letting them know about this resource so that they can work with patients to help them find their way. So that's the second one we wanted to talk about, and then Trish will introduce the third one.
So the third one's from the beginning, we wanted to tell a patient's story. So obviously my background is oncology nursing. So I used to work in Bendigo Health as, giving chemo up there. And I knew of a patient that came down for us for treatment, and then was on a clinical trial currently at Peter Mac. So we started talking to her along the way. So this is her story. And thankfully they're here tonight. So they've travelled down today, apart from the fact that it's crowed red in the Mallee, they've come down. So that's fantastic. And so we'll just tell their story. They're happy to answer questions afterwards if you like. Okay, do I need to change those lights or maybe just the lights?
My name is Rhonda and I've lived in Menangatang all my life. I was married when I was 20, Keith was 23, and I've got good sons, and one's on the farm, and when Keith's away he trots up twice a day to see that I'm okay. When I was 56 I got breast cancer. I had the treatment in Bendigo under Rob Bloom. That I kept going there for 5 years and I got the all clear after the 5 years was up, and they found that I had a rare cancer on my lung. It was at that stage another primary. So I had a part of my lung removed and I had radiation and chemotherapy. Yeah, I was going well for 4 years, and then they found that it had spread. And then I had chemotherapy and that wasn't working in the end. 18 months ago that wasn't working. Rob Bloom contacted Dr. Michael in Melbourne, the oncologist, and they said a trial was coming up. I got on that trial. I go there every fortnight to Melbourne. Well, Keith's always been there for me, he comes down to Melbourne when I have treatment all the time. And Ken he stays behind on the farm because he has to run the farm, because there has to be someone here to help look after the animals and things like that. And but the last few times that I've only had to have CT scans, I've gone to Melbourne by myself. And I never thought that I would ever do that. But I feel quite good when I can do that. And it saves Keith coming away from the farm because there's always something that he has to do. It'd be good to be back in Bendigo, but the trial's in Melbourne and that finishes this year. And I feel comfortable down there on the trial, but I think it would also it'd be the same if I was back in Bendigo. It'd be easier. Now I'm used to travelling, it's not so far to hop on a bus and go to Bendigo if it need be. Well, we've got no GP at the moment and we haven't had probably for the last 2 or 3 years. So if you want to see a doctor, you have to go to Swan Hill or Robinvale. But most times my appointments are in Bendigo or Melbourne, so that's where I go because I feel comfortable and safe there because I get so well looked after in Bendigo and in Melbourne. And the staff and the doctors were all so good to me. the trial's been really important, and when I was on the trial for a while, it did affect my lungs, so I had to go off it for 3 months because it affected them quite badly, and I really wanted to keep on the trial because in January 2020 we would be married 50 years, and later on in that year the Mowat farm has been in the family for 100 years, so I'm glad that I'm still on the trial. I don't know what's going to happen come November. That's 2 years gone, and I haven't asked really what happens if I'm still here. Can I still receive some of that treatment, or do you just go off it, or do you have to pay for it? I don't know. That's some of the questions I'll have to ask soon, because it is an expensive treatment. If the farm had to pay out all that money which they can't afford, what would you do? I think if I knew that I didn't have long, well, I think I'd say I wouldn't have it. I don't want to travel overseas, and I'm just happy with the family and getting out with friends. The houses are old, but I love them. I call them home on the farm.
Minutes to go. Okay. I just wanted to make a special thanks to Sylvia Yeo, who's sitting over here as well, who we gave all that footage to. It just came from an iPhone from us having conversations with Rhonda, and she distilled the key messages from that story. Did anyone have any questions?
I should just interrupt because Keith and Rhonda are here, and we wanted to let you know that Rhonda's message is that she's going okay, and it's lovely to see Rochelle here, who is the trial nurse. So she's back on the trial. The trial's still going, to answer that question anyway. And I guess we should just mention that video has been quite powerful in advocating for maybe regional clinical trials and for advocacy and leverage for travel and accommodation reimbursement, because you don't always get it on if you're on a trial. So it's been an important story, and we're very grateful to Keith and Rhonda for their contribution for that. And hopefully it raises metropolitan clinical awareness, if they didn't already have it, of the challenges that country patients face when they're travelling to Melbourne for their treatment.
Yeah, and around scheduling. So those 8 o'clock appointments aren't so great.
Thank you very much.
Thank you. If anyone didn't have any questions.
Thanks so much, Chris and Trish and Rhonda and Keith too. So our next presentation is on a collaboration with the Australian Cancer Survivorship Centre. The Survivorship Centre has a multidisciplinary team working to improve outcomes for cancer survivors. And today we have the Centre Manager, Helena Kelly, here to tell us about the WCMICS funded initiative called mycancerplan.org. So please join me in welcoming Helena.
Thank you. Hopefully you can hear me okay. Thank you, Rhonda, for sharing your story. I feel really honoured to have heard that. So a massive thank you to you both for sharing, and possibly less so to you, Sylvia, for scheduling me right after that. That's a bit of a hard act to follow. I have no videos. I'm just here to talk. So, I feel hopefully there'll be something in there. So I'm from the Australian Cancer Survivorship Centre, and for those of you who don't know, we're based here at Peter Mac, but we have a statewide role, and really we see that our role is to support and enable optimal survivorship care for all Victorians and their families, and we have three main areas of work drawn up there. So who is a cancer survivor? A person is considered to be a cancer survivor, as many of you will know, from the time of their diagnosis throughout the rest of their life. But the survivorship phase really provides a focus on the time after initial treatment. So we really want to focus on the time, on the health and well-being after someone's finished their primary care and are in the follow-up or survivorship phase. Just to recognise that that term survivor doesn't sit well with everyone, and I hear that and we recognise that. So when I say that word, if it doesn't fit for you, insert whatever word does. We use it for ease and so that people can know what we're talking about. So does anyone know what a survivorship care plan is? Can you put your hand up if you know what a care plan is? Some people? Fantastic, far more maybe than some of the other presentations we've given. So a survivorship care plan is a written document that's created by a person's care team with the person, and it includes information about the treatment they've received, their recommended follow-up, and then wellbeing recommendations and how to look after themselves. So it does help that transition from active treatment to after treatment. Ideally, it would help coordinate care between health professionals and that it's a communication tool. And I'm pretty sure that in the handouts you've received, there's a handout there called Survivorship Care Plans, what they are and how to use them, so if that's of interest. So why are survivorship care plans useful? We know that often people can be unprepared for that post-treatment phase, and they might be unaware of health risks and things that they can do to reduce their risk or provide a healthier lifestyle to reduce risk. We know that there are often symptoms and issues that are under-recognised and under-treated in follow-up care, and Rhonda's story highlighted some of those really nicely. That might include issues around finances and expenses related to your care. That might include travel, worry about cancer coming back, these things that often are missed in our follow-up appointments. We know that people have many follow-up appointments, timing of those can be important, and many travel long distances for their reviews. In terms of the community health professionals, like our GPs, we know that they might not feel adequately engaged in the care of survivors, so that if they've had a person who's been diagnosed with cancer, that person goes and receives their cancer treatment largely outside of the realm of the GP and then just sort of appears back after their cancer treatment has occurred. And so GPs might not have the information and support that they need to support cancer survivors in that follow-up phase. So are survivorship care plans endorsed? I guess yes, nationally and internationally there is endorsement that survivorship care plans are beneficial and that they benefit patients. So the document here is the Institute of Medicine report from 2005 that had a recommendation that when people finish their primary treatment, they should be given a comprehensive summary of that treatment and then what the follow-up plan is. That was a US document. In the UK, Macmillan have a recovery package that includes a treatment summary and a cancer care review as standard. More locally here in Australia, COSA, or our Clinical Oncology Society, have a model of survivorship care that advocates for the same things, a treatment summary that's related to a care plan and information and support for cancer survivors in that follow-up phase. Of course, our optimal care pathways give us advice that treatment summaries and follow-up care plans are really beneficial. And, oh, sorry, something's gone a bit funny with the formatting there, but just to say that there are some published papers that have come out of our program. One of our project managers, Nicole Canane, who many of you may know, has written a paper called How Will Cancer Survivors Use Survivorship Care Plans? And the main point that I was trying to highlight, which you now can't see, is that of the 219 people included in that survey, so they were cancer survivors, and we asked them, would you be interested in a survivorship care plan? 98% of them said yes, that they want one. So it's pretty hard for us to find a reason not to move forward with survivorship care plans. And so we created mycareplan.org.au with the help of WCMICS. So what it is it's a website where people can go, and it's a free online survivorship care plan generator. So it makes you a care plan. It includes all of these things that are ticked. Because we're going to walk through it, I'm just going to move on. Wanted to share the good news with you. So we launched My Care Plan in March of this year, and since then we've already had over 1,000 users. But actually, since we made that banner, we've had over 1,100 users to the end of October. And so there's good interest in these in My Care Plan. And this table is possibly a little detailed, but I guess the bottom two rows indicate what percentage of people using it are health professionals and what percentage are consumers. And what we can largely see is it's about a 50-50 split. Half of the people using it are cancer survivors themselves, and half of the people using it are health professionals, which is great. So I'm just going to step you quickly through how easy it is to use the website to create a care plan. This is the front page of the care plan, so you just click Get Started. We tell people that there are 3 steps in order to create the plan, and we do that because if you're a patient or a cancer survivor yourself, you want to know what information you need to make the plan, basically. And some people may have that information, and some may need some help from their doctor or health provider to get it right. So we ask, are you a doctor or a healthcare provider? And in this case, I've done the example that I'm not. I'm just myself completing the plan. At this stage, My Care Plan is available for 3 cancer types: early stage breast, bowel and prostate, and we would hope to expand in the future, but they're the 3 that are available at the moment. If you are a person in the audience who is interested in having a care plan and your tumour stream isn't represented here, please reach out to us, because there are some other templates and supports that we can provide you, even though it might not be reflected today on the screen. So we ask people specifically what treatment they've received, and this is primarily the bit that people might need some support to get right, because there's some technical terms in here. So for the sake of this example, I've said that I have had a removal of the breast and that I've had some adjuvant chemotherapy. And the reason that we ask people specifically what treatment they had is that in the background, this is all going on to deliver a tailored plan. Depending exactly what treatment you put in that you have had, it will tailor the results for you in a different plan to someone else who might have had a different combination of treatment. It now asks me, do I have any current side effects? And I just tick those that are relevant for this example. So I've ticked tiredness and hair loss from the chemo that I had. Wellbeing changes. It mentions that there are topics that can be provided some more information to me. So I've just ticked some topics that might be of interest: being more physically active, having a healthy diet, and some sun safety. And so it tells me my care plan's ready. So it's really quite simple. There are a number of options for what I can do with the care plan from here. I could download it and print it for myself and take a hard copy with me. I could send it to someone via email, and I can leave it there and review it. So it's something that people can go back to, and it is something that can change over time. So here's the care plan. This isn't obviously like the full thing, it's just the top to give you an example, but it talks to me about how to use it and that I should discuss it with my doctors and that it's not a standalone document, so aiming to inform and communicate with others. So in terms of, how you can be involved after hearing about this, if you didn't know about my care plan, cancer survivors tell us that survivorship care plans are simple, but that they're very important. And so if you are a cancer survivor, you might like to consider making a survivorship care plan. And if you're a health professional, you might like to check in with your patients who've had cancer and see whether it's of interest to them to make one, and can you help them or support them with that. So this is our team and our key message, that we recognise that cancer treatment is different for everyone, and that having a personalised, tailored care plan to share with your health professionals can make things easier. And so just to acknowledge WCMICS for providing the funding for mycareplan.org.au and the web interface of that, and of course for the invitation to share these results with you. Acknowledge our ACSC team who all worked really hard to get this up and running, including Sandra Picken, who was the project officer who led this work. We'd like to acknowledge DHS and the fact that they supported the database that I showed you, the background piece that provides the information and shoots that through to My Care Plan, and they also fund our program and all the users of My Care Plan. So thank you, and I'm happy to take any questions. I would just make one more comment. We do have a cancer survivorship conference coming up in March of next year. It's open to health professionals and consumers who would like to learn more about cancer survivorship. And so if you're interested, you can go to our website and find more, or there's the survivorshipconference.com.au. But back to questions if anyone would like to ask it. Yeah.
What is the structure you've put in place for maintaining that database? I mean, OCP changes over time, new things get added, different approaches take place. Is there a funding program in place to make sure the database stays up to date?
Yeah, well, thank you. That's a really important question, that what the data that is in there is accurate. So we have a plan in place to have annual reviews through our team. The answer to whether there's additional discrete funding, no, there isn't, but we consider that it's now an important part of our core program, and so we will maintain that. If, as I said, we would love to expand, but that probably would require some discrete funding, but as it stands, we'll maintain the database as part of our program.
Can I just say congratulations? It's patient empowerment as well.
Oh, well, thank you.
Thank you.
Yes.
That's a great plan. My question is regarding, because the cancer survivors are diverse in a point of location and linguist.
Yep.
Is this website is able to answer that if somebody doesn't understand the English, or literally they are not able to use the IT? What's the situation in that regard?
So at the moment, the website is available in English only, but you raise a great point that does limit who can access this resource. There are a number of resources we do have available that are in other languages, written and in audio on our website. But you make a good point. As it stands, no, this is in English. So ideally, a patient would perhaps sit with a care provider or a family member who was bilingual or had some English skills. But you're right, it's in English only.
And in a point of privacy, how the information is stored securely?
If people would like to download a copy, we don't keep the results or share them with anyone, but if people download a copy locally to their computer, then they would have control over how that's used. If they print it out and decide to provide it between their healthcare providers, it would be treated as a part of their medical record.
And my last question, in the point of designing this website, is there any, or was it any consumer rep involved in the point of using the jargon or simple language or digestive information for the patient? Yeah,
it's one of the reasons that we ask people at the start, are you a cancer survivor or are you a health professional, is we recognise that language is not always consumer facing. Yes, there was consumer involvement and always is in our projects, but it was important that the database was able to make a tailored plan, and so in order to do that we needed that really specific information, and so that's why it's got that interface.
And is there any tools to evaluate this site? Is there any metric measurements, how successful it is?
Well, I guess some of the measures we're using at the moment, and I think I'm getting the wrap up, but I think some of the measures we're using are informal feedback that people are providing through. We promote it in many forums, and I guess we are continually asking people to please provide us feedback. So I'd put that to the group. If you haven't used it, you have a patient who it would be relevant for, please do use it and provide us your feedback. We're certainly capturing stats about where and how it's being used, and it does have an international reach at the moment. So we'll keep you updated. Thank you.
Okay, next up we have Clarice Tang, who's a senior physiotherapist at Western Health, and Clarice will take us through the highlights of the CoPrep project, which was to co-design Prehabilitation Program for patients with prostate cancer at Western Health. So please welcome Clarice.
Thank you, Michael. All right, I think we've got a fairly similar theme here today, where we are presenting a lot of work that involve consumers and being part of the bigger picture of what we are trying to do. So just to provide you a bit of background in terms of our project, prostate cancer, without a doubt, is one of the most commonly diagnosed cancer among males in Australia. While the options of treatment for prostate cancers are readily available and have significantly positive results, the side effects of the treatments often leave people or men with decreased physical health, decreased psychological health, and also poorer quality of life. So prehabilitation is one of the, it's probably not really a new concept, but it's a thing that actually people are talking about in terms of providing some form of exercise or education to better prepare the patients before actually receiving some form of treatment prior, so as to actually improve their treatment outcomes. And there's evidence to suggest that the prehabilitation, introduction of prehabilitation for men with prostate cancer do improve physical health and also decrease the psychological distress and also post-surgical complications following completion of the treatment. However, majority of these prehab programs have difficulties actually engaging patients. And that's one of the things as a researcher that I find is we've got fantastic ideas and with expert opinions. And as a researcher, you know the evidence in terms of what works best. However, we often forget about the fact that the product is actually meant to be used by the consumers. So what do the consumers actually think? And more importantly, I think that the consumer lack a voice in terms of designing a program. And therefore, instead of actually asking the consumers asking the consumers whether you are satisfied with the prehabilitation program or not, we decide to embark this experience-based co-design journey, which involve setting a plan in terms of what we're actually going to do, engage with the consumers, and in this case, they were the prostate cancer survivors within Western Health, trying to interview these patients and capture their experiences, and really what were their highlights in terms of throughout the journey of their throughout the prostate cancer journey, but also what were the challenges that they experienced while undergoing prostate cancer treatment. Following the understanding of these experiences, I will take a step back. Apart from actually understanding what the consumers actually need and want, we also wanted to find out what the expert panels or the health professionals actually feel. And what we actually did was we conducted different sets of workshops, brought people together to actually understand each experiences from both sides of the story. And also through this actually combine health professionals and consumers together through a collaborative manner in terms of conducting this co-design project. And we also evaluated the co-design project at the end of the day. So the key aims of this project was really to design a prehabilitation program utilizing the experience-based co-design. And also through these, we would like to identify some of the positive experiences and challenges that prostate cancer survivors actually face, and propose some of the opportunities for improvements. So I think the first thing I wanted to highlight was we actually did manage to find consumers, or in this case, prostate cancer survivors, and more importantly, their partners. And we actually got them involved in a short video clip where we filmed at the commencement of the workshop. The idea of this short video clip was basically for them to actually share their experiences going through the prostate cancer journey, and also highlight some of the challenges that they actually face. And these actually forms the key themes in the workshop discussions, and also allow the health professionals and the patients to identify key strategies to work on these challenges. As mentioned earlier, the second step was actually to conduct the workshops. Now, we do recognize at Western Health that we do have a fairly culturally diverse population. So apart from actually engaging patients from an English-speaking background, we also embarked the journey of actually engaging our Vietnamese patients, Vietnamese-speaking patients, because that's one of the largest populations of health population that Western Health Health Services. So together, we conduct these 3 separate workshops, trying to gather their highlights and the low through their prostate cancer journey, all while they are delivering care to the prostate cancer patients. Then we pull these 3 groups of people together into one big workshop where we work together to actually develop this Prehabilitation Program. And here are the results. So in total, we had 8 patients, 1 support person, and 11 health professionals attending the various stages of the workshops. So 2 of the patients in particular were from a Vietnamese-speaking background. We do had a very good representative multidisciplinary team members being recruited, which include 4 medical and surgical doctors, 2 nurses, and 5 allied health professionals. So what were the positives? I think overall, both health professionals and patients actually valued and felt that they had a very positive experience in both receiving care and also providing the care. So in the yellow kind of speech bubbles, they actually represent quotes that were derived from the health professionals, and the blue speech bubbles represented quotes derived from the patients. So overall, everyone is kind of happy with that they're having a positive experience. And for the patients that actually receive some form of advice or some form of physiotherapy prior to actually having the surgery, they felt that one session of the physiotherapist treatment prior to surgery actually made a whole lot of difference. So they really valued the fact that there was some form of support prior to going into the treatment. However, not everyone actually got the same amount of service. So back at Western Health, the only patients who have been identified to require radical prostatectomy will have some form of support from a prostate cancer nurse and receive some form of allied health interventions. But the patients who have to undergo radiotherapy, chemotherapy, or hormone therapy often don't receive this same treatment. And what happens was the fact that men then felt lonely, anxious, and frustrated. And I don't think these quotes that represents their worries, anxiety, and frustrations will be unknown to everyone in this audience. I think this is quite a known fact. But most importantly, what the men felt really frustrated with was the fact that they were given a diagnosis at time of seeing the oncologist or the urologist, told that they need to have surgery, and then off they go. No one talked to them for 4 to 6 weeks, only to actually then come back to actually have the surgery. So the men did express that was actually the most frustrating and lonely time, where they felt that they had no one else to actually talk to. In addition, there was also a lot of pressure on the other side. Okay, there was also a lot of pressure from the health professionals' points of views in terms of trying to actually capture everyone that is relevant. And there's also a lot of discrepancy in the information that people were provided and received. So some patients got conflicting advice from their GPs, or also conflicting advice from even nurses or pre-surgery nurses when they came for their pre-operative checks. And that actually basically confused a lot of the survivors. So therefore, we came up with this solution. So co-prep became the solution to many of these strategies. So what we decided to do was actually to conduct a prehabilitation program. We decided it was going to be a really short snapshot of a program that only requires 2 weeks of involvement, with the first week including a 1-hour group education session, and also 1 hour of exercise. And then the second week will include 1 hour of exercise. Now, it's also important to know that in order to, in a way, relieve the health professionals from trying to capture the appropriate patients, we actually we had buy-in from our urology team to embed co-prep as a part of a standard care package, which meant that when patients been diagnosed that they need prior treatment for prostate cancer, okay, they will be directly referred into the prehabilitation program. So the other thing that we wanted to target was delivering education that actually meant something to the consumers or to the survivors. So what we actually got people to do, which involved the health professionals and the patients, was to get them to vote what topics were most important in their opinion that's going to help them better prepare themselves for their upcoming cancer treatment. And the key things that have been identified are basically highlighted in yellow, which are revolving around the diagnosis, the side effects of treatments, and also more in terms of the well-being. And I think in this case, I would also like to tie in with Helena's work with the survivorship. I think these themes actually kind of flow quite nicely through, and it will be, yes, and I think that if we can encourage people to think about survivorship even before they actually undergo treatment, then it will be a nice segue into the survivorship care plan. So to wrap up, I would just like to thank WCMICS for this opportunity to actually present today. But the key take-home message are as follows. Firstly, I think with this project actually highlights that it is possible to actually engage our consumers in developing health programs rather than asking them whether they are satisfied about the health program after we've developed it. Secondly, it was actually feasible to use EBCD methods for men from KEL background, and I do echo the previous person's question about the fact that we often do not include these populations, and it's probably, I like to urge the audience to also think about involving them in future projects. And just to give everyone a quick update, we're currently piloting this model back at Western Health with the aim to further refine the program. And the key aim is to really continue to provide quicker access, develop peer support for the patients, provide them with some form of support prior to actually commencement of treatment, and with the aim to expand this model into other types of treatment and also other types of cancer groups. So hereby, most important, I'd like to acknowledge the patients and the caregivers who have participated in our workshops and the co-design process. Also, again, to WCMICS for the funding and also the invitation to present the key findings from this project. And last but not least, I'd like to thank the audience for taking the time to listen to what I've got to say. Thank you.
Are there any questions for Clarice? Ian again?
Sorry to ask two questions in a row, but any thought of including participation in co-prep into the patient outcomes measurement for prostate cancer?
That's a very good idea. Yes. So I think what we have for the pilot, just to inform you, what we've actually done is that we are looking at, we have actually collected some key outcome measures mainly related to sexual dysfunction and urinary incontinence. But we are also tracking these patients through to see what the results were actually during treatment and also after treatment. But definitely something that we would incorporate.
Hi, Clarice. I just wanted to know what some of your learnings were using the co-design process, because it's something that we're quite interested in doing as well.
Yes, all right. I think the co-design, First of all, if I can give everyone some tips, maybe I'll give to people 3 tips really quickly. So the first tip I will give is you do need to find your champions. So they, in order to get a robust, rich data from your consumers, we have actually purposely seek these consumers out and actually got people to who were willing to actually give negative but also positive feedback as well. So I think that's important. Secondly, it is very important to get a professional and proper facilitator. I don't really think health professionals in particular or researchers are very good at that, I have to say. So we were very lucky to have a very professional facilitator who is well versed with the EBCD model, and I think that actually made a really good outcome. And last but not least is really getting a lot of the buy-in from the health professionals and having a wonderful project team to actually support us. And I would like to thank Sally, who is in the audience today, and also Alana for their support in this project.
Thank you, Clarice.
Yes.
So the next project, Road to Recovery, was a collaboration between Western Health, St Vincent's, Peter Mac and Royal Melbourne to support patients undergoing curative upper GI cancer surgery with an optimal nutrition care pathway. And today we'll hear from the project lead, Irene Defteros, a senior clinical dietitian at Western Health, who will take us through the project highlights. Thank you, Irene.
Hi everyone, and thanks for having me. I'm really proud to present the results of this project. It's been the accumulation of a lot of hard work from a lot of people across 4 different health services, and we've managed to create something really wonderful, and looking forward to sharing some results with you today. So when we think about the grueling treatment journey that patients with upper gastrointestinal cancer sometimes face, I quite like to use the analogy of a mountain. So if we think of surgery as the top of the mountain, there are often quite a lot of obstacles that patients might face, certainly going on the way up the mountain and then on the way back down. And malnutrition is one such significant obstacle, and it's actually prevalent in 50% of Victorian patients with upper GI cancer and is independently associated with poorer clinical and surgical outcomes, including things like increased length of stay post-surgery and an increased risk of complications. And so it's really important that nutritional intervention should really be starting at that very time that the patient decides to start that journey up towards the mountain. But sadly, in Victoria and certainly also in Australia, and I know even around the world, there's quite a lack of outpatient funding for patients to receive nutritional support before and after their surgical treatment. So similar to what Clarice was saying, patients will often just go to the top of the mountain, come for surgery, and they'll see their dietitian after they've actually had a significant surgery, such as having their entire stomach removed. And some hospitals do have some processes in place, but often there are quite significant variations across different health services, and so that leads to a real problem in terms of not only inadequacies but variations in care across health services. So we thought that this was a significant issue that we would like to have a crack at addressing, and with the help of WCMICS, we were able to fund a multi-centre pilot feasibility project, actually looking at implementing a pre-operative nutrition care pathway for patients undergoing these types of surgeries. And so, as Michael mentioned, we partnered, Western Health partnered with St Vincent's Hospital and with Melbourne Health, and we also had input from Peter Mac for those Melbourne Health patients who were having their pre-operative chemo or radiotherapy treatment at Peter Mac. And we had a 6 months pilot period which ended earlier this year. So our aims were to actually develop and implement this nutrition care pathway and to then really investigate feasibility. Was this something that we were able to achieve, and what were some of the outcomes that we found along the way? This included patient and staff satisfaction and experiences, and then we wanted to have a look at whether our pathway actually did make an impact on these patient outcomes, such as hospital admissions, how many patients were having access to nutrition services, and we used a retrospective patient group that we collected data from the medical notes to actually make some comparisons, because we wanted all our patients to have access to this service and include them all in the pilot. So in terms of actually going about the project, we conducted a structured implementation process across all sites, and this involved stakeholder engagement, including the dietetics managers, executives, our surgeons, our oncologists, really to get their buy-in in terms of making this process work. We conducted a context analysis at each site, looking into what are some of the barriers and enablers to actually implementing this type of model of care at each specific hospital and tailoring some of our strategies for those particular hospitals. We then got together as a group, and I know it was quite a long process to go through actually what the nutrition care pathway would look like, but we had extensive stakeholder feedback again and came up with something that was going to be consistent across all sites. We then rolled out this model of care, and we had a really nice supported implementation process so that this new process was able to be implemented as successfully as possible by the clinicians on the ground. We, of course, then conducted our pilot period and collected our patient and satisfaction data along the way. And then the fun part was, of course, the evaluation and the results, which we're still working through, but certainly have some results to share with you today. So just before I go on to the results, I wanted just to give you some context about what this nutrition care pathway actually looks like. This is a very simplified version. I can see some smiles from the audience. Basically, it involves, it's centred along key treatment time points right from diagnosis to the surgical time point, and dietitians actually attend the weekly surgical and oncology meeting to identify new patients really early and to self-refer to get patients into the pathway as soon as possible. The pathway then outlines the type and the timing of dietetics treatment that each patient should receive based on their nutrition assessment. So it really helps to guide the clinicians as to what type of treatment the patient should be getting. And the key components of the pathway were actually the setup of a dietitian outpatient service that aims to sit alongside the surgeons and the oncologists in the weekly clinic. So it not only facilitates that multidisciplinary care, which is often quite important if patients are experiencing symptoms. We need our medical colleagues to help us with that, but also it captures patients whilst they're already at the hospital seeing their doctors, so that the patient appointments are patient-centred and they're able to have pretty much a one-stop shop. So that's the outline of the pathway. So in terms of the project participation, over 6 months we had 35 patients actually enter the project, and that was the majority of patients that we approached. However, we had 23 actually complete the project, and this was largely because patients sometimes became too unwell and either their surgery was cancelled or postponed, and so we had to stop their data collection. But overall, it was a really good recruitment rate in terms of the numbers coming through versus the numbers we were able to capture for data. We then matched these with our retrospective patient group that we collected data from the medical records. So we had quite an even spread in terms of our gastric, esophageal and pancreatic cancer patients entering our pathway. So the blue is the retrospective group that we collected data on, and the purple is the patients that were in our pathway. And just in terms of differences between the two groups, we didn't find any real differences in terms of age or sex or anything like that. So now to the fun part, the impact of the project. In terms of patients actually receiving dietetics care, we found by implementing a structured nutrition care pathway, we were able to significantly increase the number of patients receiving care before surgery. So we've actually gone from patients in the retrospective group, 55% received any form of dietetics intervention, so that means 45% received nothing. We've now gone to 100%, which we're really proud of. In terms of the timing of these appointments, we really want to get patients in as soon as possible. We've gone from 31% of patients having a dietetics contact within the first week of diagnosis to 77% of patients having that vital contact with the dietitian right from the very start of their journey. In terms of preoperative chemoradiotherapy, we were already really well funded for that area, and so we've gone from 100% to 100%, so you can't really do much better than that. In terms of the location of the service that patients received, the aim of the pathway, again, was really to capture patients before they became unwell or before they had surgery. So we want our contacts with patients to be in the outpatient setting. And what was really interesting is that if we look at the middle graph, inpatient contacts, so when people were in hospital, they didn't really change. However, the average number of contacts in the outpatient setting or via phone significantly increased again. So that means we're being really proactive in catching people when they can really start to make a difference for their nutrition. And we used phone contact for a lot of our rural and regional patients or patients who were unable to attend the clinic at that time. Another important outcome we looked at was feeding tube insertions. A lot of these patients become quite unwell and unable to eat and drink enough to maintain their nutrition, so it's quite important to have proactive feeding tube insertions in order to maximise nutrition before surgery. And we actually went from patients in the preoperative chemoradiotherapy space. We had no feeding tube insertions before, but then we actually had 22% increase in that. And we seem to think that that could be because the dietitians are in there with their surgical oncology colleagues, communicating about these patients really early and facilitating that earlier intervention at the right time. So again, that's really positive. We had a look at the clinical outcomes of the patient group, so looking at surgical complications and hospital admissions. Overall, as a whole, we didn't find any differences in terms of the overall group, but we then looked at the patients who did have that preoperative chemoradiotherapy separately because I'm sure most of you in the room are aware, but the journey, the length of the journey for someone having pre-op chemoradio goes for about generally 2 to 3 months, whereas if you're having surgery alone, it could be a few weeks. So there's quite a significant amount of time for nutritional optimization. On the flip side, nutritional issues can often be quite common, but we do have quite a longer time frame to help patients, particularly if we're getting to them earlier. And so whilst for the researchers in the room, not statistically significant, it was a very small sample size, 35 patients is not a huge number, but we like to say that there's some potentially clinically significant improvements in clinical outcomes for these patients. So we actually halved nutrition-related hospital admissions before surgery. And again, that could be because we're being more proactive, we're getting feeding tubes inserted in the outpatient setting, we're facilitating those conversations. We then also had decreases in severe surgical complications and anastomotic leaks, which is quite a significant complication that can occur. We also had a very significant reduction in patients requiring inpatient rehabilitation after their surgery. So again, numbers are small, and so these are really promising results that we can start to utilise to have a think about how we'd like to scale up this intervention and potentially get some more significant results. Just going on that, we looked at nutritional status. This is just for the group that entered the pathway. So we had a malnutrition assessment at the start of their journey and at surgery. And so the yellow bars represent patients who had come in at the start of their journey, and the pink represents the time of surgery. And you can see that the percentage of patients that were diagnosed with malnutrition decreased. So again, sort of leads to that conclusion that if we're able to decrease malnutrition rates, get proactive nutrition intervention happening, we can potentially reduce some of these clinical complications. So really good to know that the patients also really valued the service, and we conducted evaluation using a tool that's been used in evaluating nutritional care in the outpatient setting, and all the patients reported really high scores. So the maximum score was 5 and everyone was reporting over 4 out of 5. So the care that I received from the dietitians has improved my general health, has been very helpful, has helped me to recover faster, and has improved the results of my medical treatment. And that's really positive that patients are feeling like they're experiencing something empowering as well. Our surgical oncology colleagues also really liked having more dietitians around, which is good to hear. We found that the feedback was really positive, and that they were actually also reporting patients commenting positively to them about the type of care they received, and they felt like the dietitians were getting onto these high-risk patients a lot earlier. So what about the dietitians actually implementing this very detailed and comprehensive and patient-centred model of care? They also found it really beneficial, but of course with any best practice model of care that's being implemented for the first time across multiple hospitals, there's going to be some challenges, and that's great to capture because we're able to then use that information going forward. Dietitians found improved relationships with their surgical oncology colleagues, actually even improved clinical knowledge about the patient's journey and how they're going. And they could really see the benefits for the patients in getting onto them a lot earlier. However, there is a little bit more time than anticipated coordinating to really get to those patients at the right times. And you can see a couple of nodding heads over there. It can be very time consuming and something that we're certainly looking at in terms of sustainability. So our next steps, as I just mentioned, we're continuing to evaluate the really robust data set that we have in terms of feasibility outcomes that we collected. We, of course, really want to share our results and learnings for other people that are wanting to get this type of model of care going for their patients, and we're hoping to publish those results as well so that they can be there forever for anyone that wants to look up the project and learn from our experiences. And we're also hoping to potentially apply for some bigger grant applications in future using the data that we've obtained in order to get some more results for our patients. So I was asked to give a take-home message, and I think, it really rings true, not just by this project, but also all the projects that are being presented today, that there really is significant power in collaboration, and together we can do so much more for our patients in terms of having a positive and far-reaching impact. And so thank you list is really long. Of course, I'd like to thank WCMICS and our fabulous project officer, Sally, and the project dietitians at each site, including their managers, our surgical oncology colleagues and clinic nums, and our other outpatient clinic staff as well. And of course, our participants. I put them first on there, so thanks.
Might have time for one quick question for Irene.
That was fantastic to see such a thing in the nutrition when it comes to the cancer patient. Two questions. When in part of your stakeholders' engagement, I couldn't see any GP. My question is, why is that? Secondly, when we are talking about the dietitian when it comes to the cancer patient, are we talking about the specialist dietitian, or do you believe? And the last part is, how did you cope when it comes to such a EMR and storing the data and something like that?
Yeah. Okay, I'll answer the first question about GPs. Yeah, look, it's a good point, and we tried to get as far-reaching a stakeholder group as possible because the patients are quite in an acute phase of treatment that's quite centred around the hospital. We're starting off a very new model of care that's dietitian-focused. We didn't have a GP. We had our surgical oncology colleagues, which we tend to liaise a lot more with than the GPs at that stage. If we were implementing a post-operative nutrition pathway, certainly the GPs would be probably first on our stakeholder list, but yeah, certainly something to consider. In terms of specialist dietitians, yes, I'm very passionate about the role of specialist dietitians, particularly in this complex patient group. So all dietitians involved had expertise and were already well established in the units at each site. And the last question was about EMR. Thankfully, EMR had just come in when we started the project, and we were able to navigate patient records using the existing system. So we didn't have to learn any new systems, but there were challenges with missing data, but we accounted for that in our analysis and made sure that things weren't misrepresented with missing data. Yeah.
Thanks, Irene. So, next up, we have Associate Professor Leslie Stafford, Head of Clinical Psychology at the Royal Women's Hospital, and Michelle Sinclair, who's Project Officer and Psychologist at the Centre for Women's Mental Health, also at the Women's. They're going to share with us some insights from their project, Pregnancy and Cancer. Do our cancer services meet the mental health and supportive care needs of women with gestational cancer? So please join me in welcoming Leslie and Michelle.
Hello, and thank you for the opportunity to speak today. I think the Women's is a very special place to work because we have an opportunity to work with new life and lots of babies coming into the world. And we also have that privileged opportunity to work with people who are facing a threat to their own mortality. And this is captured really well in women in whom cancer is diagnosed in pregnancy. It's quite a small group, probably 1 in 1,500 pregnancies, but a very vulnerable group. There's not a lot written about these women. A handful of studies, well, if a handful counts as 7 fingers, there are 7 studies. But that combined with our clinical knowledge suggests that these women experience quite a lot of distress, not only because they're typically young women with breast cancer or hematological cancer, sometimes a thyroid cancer, but because they have to make treatment decisions often very quickly. And those treatment decisions can have an impact, a far-reaching impact, not only on the women, but also on the fetus and on the family as a whole. So I don't need to tell anyone here, I don't think that maternity units and oncology units are very different places. And in clinical practice, these women speak a lot about not fitting in, not belonging in either place. And I guess the impetus for this project arose out of this sort of concern that these women, their mental health needs, their supportive care needs are somehow falling between the cracks, where the maternity team may well be thinking that the oncology team is looking after that and vice versa. And hence we approached WCMICS and we're very fortunate to be funded. What are we really wanting to find out? So I guess our key questions are, what are the needs of these women and what are their partners' needs? Are we meeting those needs in the delivery of care? When women speak about their healthcare experience, what makes for a good healthcare experience? Many women receive some of their treatment in public and some of their treatment in private, or all of their treatment in public, all of their treatment in private. And we don't really understand how well those things are coordinated and if in fact that makes a difference. We're also interested, particularly from the women's hospital point of view, on the impact of gestational cancer on attachment with this unborn baby and with the baby when that baby is born, and the impact on parenting more generally. Are we delivering on that promise of family-focused cancer care? And that's a question I often ask myself in the delivery of our services. Finally, we're interested in the experiences of the clinicians who care for these women. Mostly when we have a young woman coming to the clinic who is pregnant, heavily pregnant, clearly showing, and has just found out that she has cancer, usually a late-ish diagnosis because the symptoms of pregnancy are often used to explain the not feeling well, the tiredness, those sorts of things. So diagnosis is sometimes delayed quite a bit. It really stresses the team out. The stakes seem really high. I mean, we care for all of our patients, obviously, but there's something that really tugs at the heartstrings of someone who is pregnant and also has to go through this process. So I wonder, are our clinicians well equipped to look after these women? Not professionally. The medical management of these cancers is very clearly understood and documented, but psychologically, what toll does it take on them as people, as mothers, as fathers, husbands and wives? And what is the impact overall of caring for this population? What seems to be missing? So those are the key questions that have driven this project. And I guess unlike some of the other excellent projects that have been presented here tonight, our deliverable is not something that we'll immediately see in care. Instead, we're looking to develop a set of recommendations based on our findings, because what we want is to develop a coordinated, well-coordinated, evidence-based, consistent model of care that is suitable for our cancer services. We do want to deliver on that promise of family-focused cancer care. We do want to recognise what happens at home to the other children, to the father of the child or the other partner in the pregnancy, or in families where there is, say, only a single mum. We want to make sure that our clinicians are well supported, that they don't burn out, that they have adequate space to reflect on these issues. And of course, think about areas that require further research. One of the strengths we have at the Women's is a number of mother-infant therapy programs that are designed to enhance, I guess, attachment in mother-infant dyads where the mother has been unwell, either mentally or physically. And as you can imagine, in some of these pregnancies, where the outcome of the pregnancy may be undecided or precarious, one can imagine that some of these women are ambivalent about their attachment to that baby. The pregnancy may end, the baby may be unwell, or they'll have the neurodevelopmental outcomes of babies born from mothers who have pregnancy are excellent and don't differ, in fact, from the normal population. I'll also add that during the second trimester, when chemotherapy is often given, it is actually safe to have chemotherapy. So while you can't perhaps take an over-the-counter medication like Nurofen, you can actually have chemotherapy in your second trimester with no ill effects on the baby. We're hoping in that sense to gather some information that could help us refine some of our mother-infant programs with a view to potentially down the line, although the numbers are small, be able to provide these women with a tailored intervention process. So what have we done? We have recruited women who were pregnant and got a cancer diagnosis anywhere in Australia in the last 5 years, asked them to also invite their partners, although partners could participate independently, and also spoke to clinicians from across Australia. We phoned up these women, clinicians, partners, and interviewed them. So interviews were done by Michelle Sinclair, as our project officer, and Leah Collins, another psychologist also in the audience. And 3,500 minutes of interviews were done. So much so that our project is, of course, running late, as Kath knows, and I've secured some additional funding to keep going. So we spoke to these women, and I will now hand over to Michelle to give you a sneak peek of findings, I guess, related to just one area of interest, and that was around healthcare experiences.
Thank you. Okay, so as Leslie hinted, the wealth of data within these interviews was significant. A lot of these women, this was the first instance that they had spoken about their experiences, and so they were very keen to share as much as they could. So I'm going to highlight just a small portion of this data because we have such limited time. However, we analysed the interviews with women, and we found 10 very important themes central to a good healthcare experience. All of these themes were important in their own right. However, a good healthcare experience involved collaboration of all of these at the same time, so simultaneously. So I will touch on a few of these right now. So to give you a bit of an overview, the first theme I'll talk about is coordination. So the coordination of care that these women received was central to a good healthcare experience. Trust, when care was coordinated well, and this included prompt and comprehensive communication, clinicians were more trusted and women coped much better. Coordination involved communication within and across teams. So as Leslie highlighted, we're talking about teams in obstetric and oncology, but also that women can receive care across hospitals and sites. So this coordination needed to involve all of these teams and different sites. Okay.
When there was open sharing of files and records, regular team meetings with obstetric and oncology clinicians present, and when teams are working together to schedule appointments and plan treatment, women definitely noticed and their coordination was better. Poor coordination involved delayed or inadequate communication, systems that were incompatible, so inability to share between obstetric and oncology teams, and this consequently led there to be miscommunications between teams, often appointments made without results present, and this also led to a huge burden on these women to coordinate this care. Consistency was also important, and this was closely related to coordination. So when clinicians were consistent, women felt that they could trust that the clinician understood their experiences and their unique circumstances. When clinicians were not consistent, they didn't feel that they could trust that the clinicians knew everything that was going on for them. Women reported a very consistent sense that they were unique, and the way this was handled by clinicians really shaped their care. So when this was handled well, women felt prioritised. However, if this was not handled well, women felt like freaks, and they reported feeling very unique and that clinicians didn't know how to treat them. Communication is a bit hard to see there, but communication was also central to a good healthcare experience. This permeated through all aspects of their care. Prompt, comprehensive, and honest communication was most important. When clinicians communicated they were uncertain about what treatment was possible, this was okay as long as it was honest, and clinicians highlighted that they would be following this up. If communication was delayed or it was communicated in an uncertain way, women felt they couldn't trust their clinicians, and this often led to seeking second referrals and not being confident in their care. So what is our overarching message and our take-home message? That these women have a very unique experience, and they receive care across teams that were not designed to collaborate. So clinicians need to be aware that we have to have a unique approach to these women so that we are providing good healthcare experiences for them. We would like to really obviously thank WCMICS and the consumers that helped us develop in our research team and the women who participated in our research, Leah and Professor Stafford. And I think that's it. Lovely, thank you.
Again, we might have time for one quick question. Okay. Thanks to Leslie and Michelle.
Oh, sorry, my notes I didn't read.
Thank you. So next up, the project is part of the Victorian Cancer Malnutrition Collaborative, which is a statewide programme of work led by Peter Mack. The programme aims to increase understanding and knowledge and promote strategies for action in order to address cancer malnutrition. Today we have Jane Stewart, Senior Clinical Dietitian, and Emma Mackay, Clinical Dietitian, both from Peter Mack, to take us through the WCMICS funded initiative of culturally adapting the Malnutrition Screening Tool. So please welcome Jane and Emma.
Good evening, everyone. Today, Emma and I are going to tell you about our project, and it's nearing completion, and we're really excited to show you what we've created and the process involved to get to this point. So Irene has set the scene very nicely about the importance of nutrition in cancer. So nutrition is a critical component of cancer care, and cancer malnutrition is a prevalent issue for patients. Approximately 15% of all patients undergoing cancer treatment in Victoria are malnourished, and this increases to 1 in 3 patients in the inpatient setting. It's well established that malnutrition can lead to poor clinical, functional and cost outcomes, and appropriate nutrition care can negate some of these outcomes for our patients and our health system. Evidence-based guidelines recommend that all patients with cancer, irrespective of their weight history or their body mass index, should be screened for risk or presence of malnutrition to ensure early recognition and treatment. Malnutrition screening should occur at cancer diagnosis and regularly thereafter. So we wanted to give you a little bit of a background as to why we felt this project was so important. So Victoria is Australia's most culturally diverse state, with residents born in over 230 nations and speaking more than 200 languages. The Malnutrition Screening Tool, which is a simple tool used to identify risk of malnutrition, is used by the majority of Victorian cancer services and is only available in English. So in 2016, I completed a project funded by the Department of Health investigating the identification of malnutrition in culturally and linguistically diverse patients. One element of this project was to survey dietitians from 17 participating health services, Victorian cancer services. Results of this survey indicated that practices relating to malnutrition screening in culturally and linguistically diverse patients was suboptimal and far from meeting best practice. The survey revealed the perception that malnutrition screening was completed routinely in only 1/3 of cold patients. And for those that were screened, 100% of health professionals reported using an interpreter for less than 1/4 of all patients seen, and 85% of health professionals reported using a family member most of the time to assist with the completion of malnutrition screening. So it was clear that this service gap needed to be addressed. Last year, we were very fortunate and extremely grateful that we received funding from WCMICS to complete this project. The aim of the project was to culturally adapt the MST and associated malnutrition education resources into Victorians' top 10 languages other than English, to reduce unwanted variation in practice in cold patients and promote best practice in nutrition risk screening. The project was funded for 12 months with an additional 4-month impact evaluation at 12 months post-implementation of the tool. The project was due for completion in October. However, due to delays in multi-site ethics applications and the complexities involved in creating an interactive online tool, the project will now be completed at the end of December, but we've managed to kind of extend the timeframes without requiring any additional funds. So just to give you a quick overview, the project was divided into 3 phases, and we'll go through each phase in a bit more depth in the coming slides. But as an overview, phase 1 involved the cultural adaptation and translation of the MST and a malnutrition fact sheet and the creation of the online interactive MST. Phase 2 involved pilot testing and culturally adapting the online MST to establish feasibility and clinical utility. So this was really trying to figure out, does it work in usual practice and can it be integrated into usual care? And phase 3 will be an impact evaluation of the online MST and is planned to run in 12 months' time. So looking at a bit more detail at phase 1. The first step was to identify which languages we wanted to translate to. So to do this, we used Victorian admitted episode data from the WCMICS catchment over a 5-year period. And you can see the top 10 languages there. This was a very similar language profile to the state as a whole. Then we needed to determine the process for cultural adaptation. And this process followed the industry recognised standard of cultural adaptation and translation. It's important to note that resources should not just be translated word for word. They should be culturally adapted to ensure cultural relevance. And this process is actually quite involved. So as you can see here, it's a 6-step process. The next step was to create the online interactive MST, which was actually a lot more involved and complex than we first thought, and really involved the interaction of quite a few of our key players. So the media company, the web designer, the translation company, they all needed to work really closely together to get this to work. So this involved culturally adapting and translating the MST and the fact sheets about malnutrition, and also we had to create scripts for the sound files. We then had to record sound files in each language using a professional multimedia company, and we felt that the sound files was a really important element of this tool because we know that patients from culturally diverse backgrounds often are not literate in their primary language. And designing the web page with an inbuilt calculator using an external web designer, so pulling everything together. So we're going to give you a little demonstration of the tool, and then Emma's going to talk a little bit about some of the pilot testing that we did around the tool. Whoops. If I keep my fingers on it, do I, and move across?
Oh. There you go.
There we go.
That's it.
You'll see, yep. So I'm just going to run you through the English version to start with. So we added a little introduction to the tool. As this can be used by either patients themselves or health professionals, we wanted to give a bit of context as to what the tool was about. As you move through the tool, it's a very simple tool. There's essentially 3 questions, but you answer a question. As you answer one question, the next question appears. And so as you can see, the score is automatically generated with then recommendations based on tailored to your score. So do you need to see a dietitian, or are you okay and not at risk of malnutrition? But then the really exciting bit is this is available now in 10 languages. So just to run you through one of the languages. So as you can see, we've got the sort of text in each language, and in the tool, the questions are also written in English. So as a health professional, if you're helping a patient use the tool, you know what the questions are. And we also have sound files for each section of the tool. So I'll give you a little demo.
En los últimos 6 meses, ¿ha bajado de peso sin querer? Si la respuesta es sí, marque la primera casilla. Si la respuesta es no, marque
there. That's covered all the...
Yes.
So that's just a quick demonstration of the tool, and Emma's going to now tell you a little bit more about some of the pilot testing that we completed.
You can do your thanks, Jane.
Is that it? Ooh,
we're going to have to jump back into it in a minute too, sorry.
Sorry.
Wonderful. Okay, so after we completed the tool, we next conducted a pre-test phase, which was essentially an additional quality check before we planted this tool onto our website. We wanted to test it out initially first. So our stakeholders were invited to provide feedback on the clarity, comprehension and dialects. So as you can see here, the MST was well received by all the stakeholders. So all consumer representatives and bilingual health professionals indicated the question and answer options and audio files were easy to comprehend. And the NAATI accredited translators, 100% of them were very satisfied with dialects and overall clarity. So our final objective as part of phase 1 was to provide a nutrition resource to complement the online tool, with the idea that someone would complete the malnutrition screening tool and they can then access this nutrition resource to give them a bit of some initial dietetic information, nutrition information, So this step was a collaboration with the Cancer Council. We revised the Cancer Council fact sheet of understanding cancer and malnutrition, which some of you may be aware of. That went through a review process with both the VCMC community and the Cancer Council community, and was rebranded to the VCMC and renamed Preventing Weight Loss Why Is It Important for People with Cancer. So this resource is available for download after you complete the MST tool. So down below where Jane clicked before, when you get to the bottom, this tool just pops up in each of the languages. And we also have, I was going to show you the other resources, sorry, I'll probably stuff it up.
And then...
So we've also got a version, thanks Jane, awesome. So we've also got here on the Pediatric website, which is freely available, there is a fact sheet which is specifically created for health professionals, so a bit more information there about how to manage malnutrition with patients. We also have, if people don't have access to the internet in their clinical practice, we have a side-by-side translated printable version of the malnutrition screening tool there as well. Can I let you do your thing to get it back? Thank you. Slideshow. Thank you. Beautiful. So on to phase 2. So phase 2 involved a multi-site pilot test of the online interactive MST to establish feasibility and clinical utility. The phase involved 2 stages. So the first stage being a pilot of the MST with patients in usual practice. This stage went for a duration of 3 months. Eligible patients were recruited via health professionals at 3 sites, being Peter Mac, Western and Monash Health. For the means of the pilot, we just tested the top 6 languages. So an interpreter was present with the patient and the health professional as they completed the tool, and then the patient answered a series of evaluation questions after they completed the tool. The second stage was then to conduct focus groups with those health professionals who we employed to use the tool with the patients to get their feedback. So it's a little bit hard to read here, sorry, in that blue, but firstly looking at the results of the MST being used with our called community in usual practice. So the total number recruited from all 3 sites was 36 patients in total. We had hoped that we would gain more numbers than this. However, looking to the research, we do know that due to the complexity of needing an interpreter physically there to consent patients, the numbers in research involving called patients tend to be a little lower. So we weren't overly surprised. The sample was representative of all 6 languages and included patients with various primary cancer sites and treatment time points. So you can see here a summary of the results. The main questions we asked were relating to the clarity of the tool. So were the instructions clear? Were the questions clear? Were the answer options clear? And were the recommendations clear? As you can see, it's all skewed over to the positive side. So the vast majority of patients were very happy and ranked 2 of the highest clarity scales. We additionally asked patients whether they would feel comfortable using this tool without an interpreter present. As you can see, the vast majority stated that they would be comfortable or very comfortable to do so, which was also good to hear. So now looking at the results of the second section of our multi-site pilot, which was the focus groups with health professionals. So across the 3 sites, we had 7 health professionals in total take part in this, and we used some principles of implementation research to look at these results. So I will just basically go through them. So acceptability is the first one, which relates to the patient and health professional perception that the online MST is agreeable, its ease of use and its function. So you can see the tool was well received by participants. It was user-friendly, the content flowed well. However, we did learn that the online platform posed a challenge for some of our elderly population. Adoption, which relates to the uptake of the online MST. The majority of eligible patients were happy to participate. Appropriateness relates to the usefulness of the online MST. So patients appreciated having a tool in their language, which was wonderful, and health professionals felt that it filled a gap in service delivery. Feasibility relates to the suitability for everyday use. There was strong support for everyday use, and the audio feature was certainly appreciated, although we did find that it was impacted in a noisy environment, and perhaps for the elderly population, again, that it was a little bit too quick in some instances. So phase 3 is the impact evaluation. So that will be conducted in 12 months' time. What we do plan to do here, so the aim will be to utilise principles of implementation research again, to assess how the online MST is utilised by the cold population and by health professionals, and its effectiveness in completing malnutrition screening. We plan to investigate factors affecting implementation, the process of implementation, and the results of implementation. So what does this all mean? So from undertaking this project, we have reduced this service gap and improved equity of care for our cold community. The improved access to the MST should lead to reduced variation in practice. So there's quite a broad scope of impact for this project. So obviously it's readily available on the PDMAC website, so really anyone can access it, Victoria, Australia, abroad. Various health service settings can use it, so in acute, community and primary care, and anyone can use it, so the health professional, family, carers and the patients themselves. So we would certainly like to say a massive thank you to WCMICS for making this project possible. We would love to acknowledge also our wonderful project team and steering committee, of which we had consumer representation, which was great. Our suppliers who made this possible as well, as Jane said, is quite a big collaboration amongst them all. So Salaba Translations, Lifeboy Multimedia, Icon and Green Scribble. And also our pilot sites being Monash, PDMAC and Western Health. And that's all. Thank you.
Running slightly behind time, so we might leave the questions for now, and maybe if you want to catch one of the dietitians at the end, feel free to chase them down. Okay, so our final presentation this afternoon is with Dilu, who's our WCMICS Optimal Care Pathways lead, and she's here to launch a new suite of pancreatic patient resource videos, which will be hosted by the Pancare Foundation and the Unicorn Foundation. Dilu's joined by Shannon Gleeson, who's a pancreatic cancer specialist nurse from Pancare Foundation. Please welcome Dilu and Shannon.
Thank you, Michael. So you've just heard about WCMICS funded projects and how through them we collaborate with our health services to improve quality of care and patient outcomes and reduce variation in cancer care. Before I describe the other branch of our work, let me tell you who we are. WCMICS is funded by the Victorian Department of Health and Human Services and was established in response to a statewide commitment to cancer reform. Our role is to work with hospitals to improve patient experiences and outcomes by connecting cancer care and driving best practice. So the other branch of our work aligns with the Victorian Cancer Plan, and therefore a significant portion of our work is to assist our partner health services adopt the optimal care pathways. These are the national guides to the best cancer care for 15 tumour types, and their primary focus is to improve patient outcomes by collaborating with our health services and facilitating consistent cancer care based on standardised pathways. As part of the OCP program, this time last year, WCMICS patients, carers and clinicians identified the need for resources to support people affected by pancreatic cancer. Increasing awareness of how exercise, nutrition, and psychology contribute to improving quality of life were identified as important issues. A suite of digital stories on these three topics were developed to facilitate access to self-care information for people affected by pancreatic cancer. And the objective was for them to be easily accessible and complementary to existing services and resources. The titles of the three videos are Thoughts Matter, Keeping Active, Strength Through Nutrition. So I would like to thank the patients who volunteered to be part of these videos today. Marg, Peter, and Ray, who are present here today with us as well as the clinicians, Dale, Kate, Irene, and Maria, who also volunteered to be part of this. Thank you to Lifeboy, who assisted in producing these videos, and Pancare and Unicorn Foundation for hosting them on their websites. Today is also World Pancreatic Day, where we take action to raise awareness about pancreatic cancer. So I take the opportunity to launch these video resources for people affected by pancreatic cancer. Enjoy this little preview of the three videos. Thank you. So I'll welcome Shannon from Pancare to talk about pancreatic cancer. Thank you. How do you put them?
Good evening, everyone, and I'd just like to thank WCMICS for inviting us to present. And I'm a bit of a walker when I present, so I'll try and stay as still as possible so you can hear me. So Pancare Foundation, our vision is to unite a community that inspires hope and accelerates change, and to double the survival rates of pancreatic and GI cancers by 2030. So it's a big, bold goal, and we've got 10 years to achieve it.
So that should be on if you...
You can tell she's a nurse. Oh, there we go. So pancreatic survival, sorry, is that on? So 5-year survival rate for pancreatic cancer is only 9.8%, and this has only increased around 4% in the last 30 years. In comparison to other cancers in Australia, we would be looking at breast cancer survival being over 90%, and prostate cancer being over 90% as well. So if 100 people are diagnosed with pancreatic cancer today, in 5 years' time, only 10 of them will be alive out of that 100. Around 3,600 men and women are diagnosed every year, and about 3,000 die. It's currently the 10th most commonly diagnosed cancer in Australia. It's the 5th leading cause of cancer death in Australia. And in the next 10 years, it's likely that it's going to be the 2nd leading cause of cancer death. So Pancare Foundation has stepped up to the plate, and we're committing to delivering patient support services as well as research investment. So we have our patient support program. So we have a nurse specialist, which is myself, and a financial assistance program. We also run support days and have a telephone or face-to-face support groups as well. We also have our patient and dietary handbooks. So we're committed to our education of patients and carers and nurses and doctors and anyone who comes across this cancer. We've done some GP education nights. I actually presented at one last night, which was riveting. And we've got some fact sheets, and also we're getting involved in video resources, which you saw. As well as this, we also raise money to do research. So we're currently trying to discover new treatments. We run a familial screening program whereby if you have one first degree and a second degree, or more than 2 second degree relatives with pancreatic cancer, we will start to do a yearly screening for 5 years, and we'll be doing an EUS procedure as well as taking urine samples and blood samples. So we haven't found anything yet in that screening program, but the hope is that we will. We also are supporting cancer clinical trials, so new novel therapies, new chemotherapies that come along, and the current best practice chemotherapy regimes were actually only in clinical trial format about 3 years ago. So it's a rapidly progressing area. And this is just a little bit of a recap. I won't go too much into it because we're running late. But we just want to get the word out that we do have a nurse specialist. So anyone in Australia can ring up and ask questions about their diet. They can ask questions about their chemotherapy regime. They can ask about their pain management plan, or discharge planning out of hospitals, or what can I ask my GP? What do I need to know about pancreatic cancer? Because if you go into Google, those stats are the ones that are going to come up. So we'd prefer that people called us or the Cancer Council of Australia, just to get someone on the under the line that can kind of instill a little bit of hope in them. So I've got some patients in the audience today who are living the cancer journey, or however they want to say it, but they're doing a great job, and they're standing up, they're coming to the support days, they're providing this good example to others of really pitching in and having a good battle. If anyone wants to go on our socials, today is World Pancreatic Cancer Day, and hopefully we'll see some of the buildings around the world lit up in purple. We may not see it with the smoke haze out today, but somewhere in Melbourne, the town hall or the spire in the city should be lit up in purple. So please go on and have a look. If you hear of someone with pancreatic cancer in the wind, just let them know that we're there, we're available, and we'll help them through. So thank you, WCMICS, and thanks for having us.
Thank you, Shannon. That brings us to the end of proceedings for tonight. So thanks so much for joining us to hear about what was just a sample of some of the great collaborative work between WCMICS and our partners over the last 12 months. For a more detailed look over our work from the past year, you can check out our annual report, as Jeff mentioned earlier. If you're any good with QR codes, there'll be one on the handout that you got coming in, or just go to our website, wcmics.org, and you'll find it on there. On behalf of the whole team, I'd like to thank you for coming tonight, and we look forward to working with you again in the year ahead. So that brings everything to a close. Please help yourself to some light refreshments and a bit of networking time outside. And thanks for coming.